Hi everyone, this is Tim, your Block 1 lecture instructor, and today we'll be covering Chapter 11, which is Psychosocial Health and Illness. This is a pretty lengthy PowerPoint presentation, so bear with me. Take some breaks as you need to. Jot down any questions you may have, and we'll cover them in class. So here we go. The learning outcomes. I want you to be able to explain the relationship of psychosocial factors to overall health and development. Identify the factors that influence the development and stability of self-concept. List the 4 interrelated components of self-concept. Identify 10 general categories to include in a comprehensive psychosocial assessment. You should be able to perform an assessment using the domains of self-concept, self-esteem, self-identity, and body image. You should be able to describe interventions for preventing depersonalization. Describe the anxiety continuum. List the psychological and physiological effects of anxiety. Recognize the levels and symptoms of anxiety that are severe enough to merit referral to a mental health professional. And identify several ways in which clients manifest depression. You should be able to differentiate between mild depression and that which should be referred to a mental health professional. Assess older adults for manifestations of depression. Plan outcomes and nursing interventions for patients who are depressed. You should be able to discuss the critical needs of a patient with delirium, summarize interventions appropriate for a patient with delirium, compare and contrast the signs and symptoms occurring in the 4 stages of Alzheimer's disease, and finally, understand important aspects of caring for a patient with Alzheimer's disease, including guidelines for communication, health maintenance, and safe environment. So the psychosocial theory is understanding people as a combination of psychological and social events. If you turn to chapter 9, page 162 in your volume 1 book, here you'll find Erickson's 8 stages. Erickson hypothesized that individuals must negotiate 8 stages as they progress through the lifespan. Most individuals successfully move from stage to stage. However, a person can regress during times of stress to earlier stages or be forced to face tasks of later stages because of unforeseen life events, such as terminal illness. So in the second column, you actually see Erickson's 8 stages, which starts off with stage 1, trust versus mistrust. This begins with birth and it finishes around 18 months. And then as you follow the stages, it will finish with stage 8, which is ego integrity versus despair. This will start at the age of 65 and go on until their death. I want you to be familiar with these, so either Google them or find some sort of reference that will explain the stages to you. You'll find that you'll use these throughout your blocks for nursing school, and you'll also use them throughout your nursing career. Once you find out where your patient is in these stages, it kind of tells you a little bit more about who they are and where they're coming from and mentally where they're at in their life, and it does make some sense. So familiarize yourself with these stages. So the psychosocial theory, the patient's response to illness is influenced by the patient's physical pathology as well as their psychosocial health. And here you have a block wall. The bricks in the block wall represent all the things that can influence one's health. These could be your family, your friends, your education, your socioeconomic status, coping mechanisms, your career. All these things make up who you are or who your patient is and how they cope with stress and what they also believe in as far as health. I also want you to look at page 184, figure 11-1, which is the biophysiosocial view of health. The four circles represent the whole person. You want to know as much as you possibly can about each category so you can holistically care for your patient, whether it be social, biological, spiritual, or psychological. All these things make up your patient. And again, just like with the block wall, there's a lot of things that influence your patient and who they are. And once you figure out these 4 circles, it allows you to better take care of them holistically. So with self-concept, self-concept is the answer to the question of who do you think you are? These factors make up your self-concepts. So whether it be physical appearance, sexual performance, intellectual abilities, success in the workplace, or school, your friends, your family, problem solving and coping abilities, or unique talents. These are who you are, and self-concept, again, is who do you think you are. And in this slide, these are the factors that also make up your self-concept, but cannot be changed. Whether it be gender, you can't change the fact that you're male or female. Developmental level, again, this is your education, how you think, how you learn. You can kind of deviate a little bit, but for the most part, you are who you are. So socioeconomic status, I think we all believe that you will finish nursing school and you'll make a little bit more money, which you will. But you're not going to go from being broke to being a millionaire. So again, that doesn't really change too much. Family, you can pick your friends, but you can't pick your family. And your family do have a lot of influence, especially with traditions um, and things that you grew up with. That's who makes you who you are. Peer relationships, again, the people you hang around with, people you associate yourself with, those also have influences. Internal locus of control. This is your inner voice, just kind of like a gut feeling, which is influenced by your self-concept. And these are the components of self-concept, whether it be body image, role performance, personal identity, or self-esteem. So let's start off with body image. It's the mental image of physical self. It's influenced by ideal versus perceived and actual body image, appearance and function of the body, and gradual versus sudden body changes. With the first one, which is ideal versus perceived, it's what you want to look like and what you think you look like. So, I'd like to be, 6'2" and built and gorgeous like a supermodel, but I perceive myself as being average looking and not too bad, and you know, I'd say modest, I guess. So with number two, which is appearance and function of the body, again, it's truly what you appear to be and the function of your body. Gradual versus sudden body changes. Gradual is gaining weight, and sudden body changes could be the loss of a limb. So with gradual, you get used to it, and with sudden body changes, it just hits you all at once, and you are what you are. And this is role performance, the actions a person takes and the behaviors demonstrated in fulfilling a role. Let's take an example of being a mother. You're going to raise your children, and you are fulfilling that role. If you're a nursing student, you're fulfilling a role. So the role is what you play in your daily life, whether it be a mother raising her children, a father having a job, you being a nurse. Everybody has a role that they play within society and also your life in general. So here's a clicker question. So the elder client's daughter is vice president of a large company. She's experiencing great conflict in trying to care for her mother while managing her work-related responsibilities. In planning to help the daughter, the nurse focuses on which component of the daughter's self-concept. Would it be her body image, role performance, personal identity, or self-esteem? And the answer is B. The data suggests that the daughter is experiencing inter-role conflict. And the reason for that is because the daughter is a vice president of a large company. So her role is the vice president in running it. But she also has another role, which is actually being a daughter and caring for her ill mother. So she's got two different roles, and she wants to be able to fulfill them both. But the strain or the problem she's facing is whether or not she does one or the other. So with personal identity, your view of self as a unique human being, different and separate from all, and is relatively constant and consistent. So in this slide, it's actually self-esteem, how well a person likes oneself, and the difference between ideal self and actual self. I would ideally like to be the best lecture instructor in the world, but actually, because I'm just starting out and this is my first semester teaching, I know my limitations, and hopefully as I gain more experience, I'll be better at it. So there is a difference between ideal and actual, and again, the self-esteem part is you liking yourself and what your perception is. So to do a psychosocial assessment, you're going to look at biological, psychosocial, and social details. You're going to look at the functional abilities, self-efficiency, family relationships, and relationships within the wider social environment. You're also going to assess for interpersonal communication, social resources and networks, understanding current illness, and using coping mechanisms, and also health priorities. So here's another clicker question. In assessing clients who may be experiencing a depressive disorder, the nurse's top priority is determine which of the following: an onset and severity of symptoms, risk of self-harm, previous history of depression, or family and community supports. And the answer is B. It would be most important for the nurse to assess for life-threatening behaviors such as self-harm, which can include suicide. When you're also doing a psychosocial assessment, you're also going to look at these two different columns. There's a difference between the two. People do get sad, people cry, people get distracted, and people tend to have low energy, and those are typical and relatively normal symptoms. What is severe is the emptiness and total despair, psychomotor retardation, the inability to move and properly function, delusions, confusion, self-blame, and actually insomnia and poor hygiene. These are severe symptoms that are kind of a flag for you to look at as a nurse, determine if there is something more serious than just being the mild symptoms. So for psychosocial diagnoses, we must determine cause and effect. So interrupted family processes, family coping, parental role conflict, ineffective individual coping, and post-trauma syndrome. We also have nursing diagnoses of risk for loneliness, social isolation, risk for violence directed at others, or impaired social interaction. So for a self-concept diagnosis, we have chronic low self-esteem, situational low self-esteem, disturbed personal identity, ineffective role performance, and disturbed body image. There's approximately 30 standardized outcomes for psychosocial self-concept and self-esteem. The first one could be psychological well-being, psychological adaptation, self-control, social interaction. These can all be found in the psychosocial health and family health domains. For psychosocial illness, for anxiety, normal anxiety is an essential reaction to a realistic threat. Abnormal anxiety is the anxiety is still there even after the threat is gone. So for a common emotional response, usually a stressor that causes anxiety, taking tests that causes anxiety, but abnormal anxiety is even after the test is over, you're still very anxious, and you're unable to continue doing other things or function properly. So to do an assessment for anxiety, you're going to identify presence, level, cause of anxiety. You're going to assess for observable behaviors, cognitive changes, objective physical data, and subjective data. You're also going to assess immediate intervention to see if it's needed for the person who exhibits the following: suicidal thoughts or plans, assaultive or homicidal thoughts and or plans to do so, loss of touch with reality, or significant and or prolonged inability to work and care for self or family. And there's 4 different levels of anxiety. The first one is intensity, duration, normal anxiety, and finally abnormal anxiety. We already covered normal anxiety and abnormal anxiety, but intensity and duration is based on how much anxiety is present and how long it lasts. We have mild anxiety, moderate anxiety, severe anxiety, and panic anxiety. Mild is normal. You feel it when you take a test. Moderate is anxiety that increases and the person begins to focus on themselves and the need to relieve the discomfort. Severe is the anxiety is too bad or is so bad that they can only focus on one particular detail and concentration and attention is severely limited. For panic, the person becomes unreasonable, irrational, and not able to focus at all on any detail. So for a nursing diagnosis for anxiety, you have anxiety, you have death anxiety, decisional conflict, fear, ineffective denial. And for planning, you can turn to page 199, and that would be to relieve the anxiety, relieve all these symptoms here. Interventions would be to recognize that the client or the patient is anxious, identify the source of the anxiety, and deal with the symptoms of anxiety. So for evaluation is, did the interventions work? Did the patient reach the goal or outcome set in the plan, or are they less anxious? So pharmacology of anxiety, I'll have you look this up on your Skyscape, but Ativan is probably the most common. We tend to give this at the hospital. I don't want to say a lot, but for those who are anxious, we give them usually about 0.5 milligrams just to help relieve some of those symptoms. If it doesn't, then we may give them a little bit more. We could either give it IV or PO. PO tends to take about 20 minutes for it to really kind of kick in and be absorbed, and it tends to work. The IV tends to work a little bit faster, but again, those are for the patients who are having more of a severe or panic anxiety than mild and moderate. So click or check. A client with anxiety is completely focused on himself and the need to relieve his problem. He is at which stage of anxiety? We have panic anxiety, mild anxiety, moderate anxiety, and severe anxiety. And the answer is D. So coping with anxiety, there's adaptive behaviors. They can exercise, they can talk to people about it, they can engage in pleasurable activities, deep breathing, and using relaxation programs. Less adaptive behaviors is excessive sleeping, eating, smoking, crying, pacing, fidgeting, and drinking. Psychosocial interventions. These are standardized psychosocial interventions found in behavioral and family domains. So now we're going to move on to depression. Depression is the fourth leading cause of disability in the U.S. It's projected to be the second leading cause of disability by 2020. Major depressive disorder is twice as common in women than in men. And with major depressive disorder, it greatly increases among people with a medical disorder. 6 to 9% of older adults experience depression, may go undiagnosed due to its being masked by other medical conditions. So for theories, they have biological. There's genetic factors, biochemical factors, neuroendocrine factors, and image findings. Psychodynamic influences in life events. It could be environmental and life events perspective. For cognitive theories, people acquire a psychological predisposition to depression through early life experiences and the cognitive triad. So for learned helplessness, a person feels no control over the outcome of a situation and believes that the event is his or her fault. So for the nursing process, when you're doing your assessment, they have the standardized screening tools, which could be the Beck Depression Inventory, the Hamilton Depression Scale, and the Geriatric Depression Scale. These patients have a suicidal potential, and areas to assess is their mood, physical changes, and cognition. So for nursing diagnoses, a high priority is to assess for suicide, therefore risk for suicide is always considered. They have hopelessness, ineffective coping, social isolation, and self-care deficits. So for planning, include goals for safety. Planning is based on the individual's symptoms. For implementation, you have communication guidelines. You have health teaching and promotion, which could be nutrition, sleep, self-care deficits, and elimination. You have the milieu therapy. You have psychotherapy. You have group therapy, pharmacological, biological, and integrative therapies. You have somatic treatments and integrative therapies. And so for the evaluation, the short-term indicators or the goals or the outcome is criteria that need to be evaluated frequently. So pharmacotherapy, we have antidepressants, such as tricyclic antidepressants. We also have Elavil. So for the SSRIs, you have Prozac and Paxil. You also have the atypical or the new drugs, which is the Wellbutrin and Zyban. You have Effexor, Remeron, and Cymbalta, and also the MAOIs. So now we're going to move on to delirium, which is a disturbance of consciousness, a change in cognition, and the disturbance develops over a short period of time. Delirium is also somewhat of an acute confusion. You also have Sundown Syndrome, and in the hospital we call it sundowners. It's symptoms and behaviors that become more pronounced in the evening. And when I first became a nurse, I didn't believe them, but it truly does happen in the evening. Sun goes down around 5, 5:30, 6 o'clock at night, and all of a sudden your patient who was alert and oriented all day long becomes very confused. Sometimes they get agitated and angry and sometimes violent, and sometimes they just get pleasantly confused. But this can occur in both delirium and dementia. Potential causes of delirium is hypoglycemia, fever, dehydration, hypotension, adverse drug reactions, head injury, change in environment, pain, and emotional distress. Especially in Arizona, we see a lot of elderly patients who become very dehydrated. The more dehydrated they become, the more confused they can be. So a lot of times you'll get admissions of patients that are in their 70s, 80s, 90s, because obviously the older they get, the more they lose their thirst factor, and they don't drink a lot, and it's hot outside. Next thing you know, they get dehydrated and they become confused. So for your nursing assessment, you're going to do a cognitive and perceptual disturbance check. You're going to assess their physical needs, whether it's physical safety or biophysical safety. And you're also going to assess moods and physical behaviors. A nursing diagnosis could be or depend on the symptom. And according to this, you're going to take a look at your nursing diagnosis list and come up with a few. So for planning, again, it depends on the symptoms. The client will remain safe and free from injury while in the hospital. During periods of lucidity, the client will be orientated to time, place, and person with the aid of the nursing interventions. And for general interventions, you will perform a comprehensive nursing assessment to aid in identifying the cause. And say, according to this, permanent brain damage can occur if left untreated. Prevention of physical harm to self and others, use supportive measures to relieve distress, and in-class handout of potential interventions. So again, medications could be lorazepam or Ativan. I have found in my experience that any patient that is over the age of 80 does not do well with Ativan, so we usually tend to do Haldol. So we'll talk about that in class. So for the evaluation, did the patient remain safe? Was the patient oriented to time, place, and person by discharge? And was the underlying cause treated, and according to this, ameliorated, the new word of the day. So here's an actual link to a YouTube video for dementia. Dementia is commonly referred to as Alzheimer's disease, but there are different types. It is a progressive deterioration of a cognitive function. Initial deterioration may be subtle, may not be noticeable, and patients may use defense mechanisms, denial, confabulation, which is unconscious attempt to maintain self-esteem, and perseveration or repetition. I find that patients who have dementia or Alzheimer's
disease
do very well with masking their symptoms, and I also find that their spouses, because they see them every day, they don't see the deterioration. So for them, they're so used to this being the way they are that they don't believe that their spouses have Alzheimer's disease. So cardinal symptoms: amnesia or memory impairment, aphasia, apraxia, agnosia, disturbances in executive functioning. Stages of Alzheimer's disease: there is a stage 1, which is mild, stage 2, which is moderate, stage 3, which is severe, and stage 4, which is late. Stage 1 is forgetfulness, shows short-term memory loss, loses things, forgets. Memory aids compensate, which they may start making lists, they follow a routine, and they have some sort of organization. That's why when you find that Grandpa went to the store and he used the same route that he did every single day for the last 20 years, and something changes and he gets completely lost. And then we find him on the news because no one can seem to find him. They are also aware of the problem, concerned about the loss of their abilities, and depression is very common. It's not diagnosable at this time. Depression is common because, especially with these patients, they tend to be elderly and they don't want to lose their self-independence. So it scares them, and because of this, they tend to stop doing a lot of things because they don't want to show the symptoms or look confused. So they start to become depressed. So for stage 2, it is confusion. It shows progressive memory loss, short-term memory impairment, and memory difficulties interfere with all their abilities. They'll become withdrawn. They'll decline in ADLs or their active daily living. They'll have denial, which is very common. They have a fear of losing their mind. I couldn't imagine being alert and oriented and confused all the time, and knowing you're confused probably makes it even worse. If you're confused and didn't know it, then you would never know you were confused. But to live with the sometimes you're with it and sometimes you're not, that's going to be very frustrating, which will also cause depression. Problems are intensified when stressed, fatigued, or out of their own environment. Again, they like routine. They don't like change. When that starts to happen, they become very stressed, and the more stressed they become, the more anxiety-driven. And again, as we looked at before, you have the different stages of anxiety. This probably throws them out of their normal routine and just really aggravates them and gets them stressed out and causes more problems. Then they may need the patient may need daycare or own in-home assistance in order to be taken care of. So for stage 3, we have ambulatory dementia. Shows ADL losses in order. They lose their ability to bathe, groom, choosing their clothes, dressing. Sometimes they don't walk real well. Toiletry starts becoming a problem. They become incontinent. Communication starts to become a problem, and they lose their ability to read and write. They also lose their sense of reasoning, safety planning, and verbal communication. They become very frustrated. Again, they'll become depressed. They have difficulty communicating, and all of this reduces their like again with stage 1 and stage 2, they become confused, but they have little bouts of lucidity, and with stage 3, they've actually lose that, and stress also causes that to become more of a problem. So with stage 4, this is the end stage. Family recognition disappears. I've had friends who have had Alzheimer's parents, and in this stage, they would go to visit them, and the patient doesn't even recognize who they are at all. They're non-ambulatory. They tend to either stay in bed or just sit in a chair all the time. They do forget how to eat and swallow and chew, which then leads to weight loss, problems associated with immobility, which obviously if they're not eating, they're probably with the weight loss, they're also becoming very weak, so walking is going to be very hard. They'll have incontinence. They'll become institutionalized at this point just because they can't take care for themselves, and most family members can't care for them either. And they return to primitive or infantile reflexes, which it's almost kind of you come into this world as an infant and you leave as an infant. So your nursing assessment, you're going to identify and treat any general medical conditions that might contribute to the dementia. You'll evaluate potential of suicide or aggression towards others. Explore how well the family is prepared for and informed about the progression of dementia. Review medications the patient is currently taking. Evaluate the patient's current cognitive level. You'll discuss with family members coping strategies. You'll review resources available to the family. Determine appropriate safety measures. Evaluate the patient's home for safety. And identify the needs of the family for teaching and guidance. So for nursing diagnosis, it will be safety, caregiver role strain, disability family coping. And according to this, let's look at caregiver role strain in your nursing care book. So Planning is geared toward the immediate needs, the use of functional dementia scale. Again, your planning is really safety, getting them some help, and again, probably getting some sort of assistant living. Implementation, the nurse must have an attitude of unconditional positive regard. Again, you really just have to take care of them as best as you possibly can. Sometimes they're pleasantly confused, which is really nice because those are easy to take care of, and sometimes they're not. And those that are aggressive and agitated, you take it with a grain of salt, and you really just try to do the best you can to orientate them to where they are and help them along throughout the day. The nurse must have a warm, empathetic, and non-judgmental approach. The nurse must use calm, unhurried, clear communication, and the nurse must consider health teaching and health promotion. The evaluation will be outcomes, which must be stated in measurable terms and within the capability of the patient. Again, they're not really able to do a whole lot at this point, so you have to be realistic. Outcomes may need to be evaluated and altered frequently depending on the status of the patient. If they're alert and oriented, you change it, and they become confused, and you change it again. Pharmacotherapy, we have Razidine, Exelon, Aricept, and Namenda. And according to this, let's take a look at Exelon and Aricept in your drug reference. And that's the end of the PowerPoint. I do apologize for breezing through it. We're going to go over this in class and probably answer a lot of questions that you may have. I unfortunately did not make this PowerPoint, so it may sound a little scripted and a little read, maybe not as organized as I would like it to be. But this is also a chapter that needs to be more face-to-face and in classroom time. So, like I said, skim through it. Definitely go through the chapter, and we'll cover a lot of points and do a lot of activities. I think that will help concrete this, and we'll go over it.